Okay, thank you very much. And just want to say thank you very much for this opportunity to talk to you all. First off, before I begin, I'd like to acknowledge the project team and all the people that I've worked with over the past years, and also our industry collaborators, because a lot of what I'm going to talk to today is really formed from those relationships and those collaborations and what we've learnt in terms of interacting with them. A few people asked me whether I was going to talk about my career journey, and I was like, I'm an early career researcher, there's not that much to talk about. So I'll do that in 2 slides, and then for the majority of it, I'm more going to talk about something that I'm quite passionate about and that I see, you know, a lot of us were talking about NHMRC grants, looking at impact and looking at, you know, how is our research actually making a difference on the grounds? How are we actually contributing to the clinicians, counsellors and clients on the grounds? So it's going to focus more on that. So me, I grew up in Sydney from a pretty large family, which is probably why I was interested in psychology, and went to Macquarie University for both my undergrad and then my postgraduate degrees. I did a clinical masters in psychology and a PhD. And when I was finishing my PhD, I decided I would never do research again, and that I was not in research at all. But a position came up at Queensland University of Technology with Leanne Hydes' team, and it was focused in on youth substance use research. So all my undergrad, I really focused a lot on adolescents. In my clinical work, I'd worked in acute adolescent units, and so I was quite interested in that group. And Leanne assured me that I would get to do clinical work at the same time. And because of that, I moved up to Queensland to QUT at the Centre for Youth Substance Abuse Research. While I was there, I was able to continue some of the school-based work I'd done through Adolescent Aware, which is really just a longitudinal project done off the smell of an oily rag. We started with grade 7 and 8 students, and we've been following them through every year. Next year, they're in grade 12. So we have 6 years of longitudinal data. We started with about 1,400 schools and 1,400 students, and each year new students have kind of been involved. So we have about 5,000 students in that sample now. And one of the nice things about it is it's looking at substance use, mental health, risk and protective factors, but also peers. So because we had like an 80% consent rate, we actually can map out peer networks, which is quite nice. I haven't had much of a chance to analyse it, so if anyone's interested in that, please let me know, because it would be useful to collaborate with people on that. The other thing is working with the now Matilda Foundation on climate schools, which is a big prevention intervention, and just been involved in the Queensland arm of that. Collaborating with Red Frogs that do a lot of festival and schoolies activities, and really just working with them, looking at one of their pre-schoolies interventions that they did, and evaluating that and other interventions and looking at that age group. And then finally working with the YMCA, so with disengaged young people and helping in terms of the development of an intervention to help them stay engaged in school. A lot of these were obviously experiencing substance use concerns, but trying to help them stay engaged in school, getting into the workforce and things like that. My contract at QUT was finishing up, and so another opportunity arose at the University of Queensland. They developed a partnership with Lives Live Well, which is the biggest drug and alcohol treatment service in Queensland. They deliver a range of services, so both community and outpatient. They have some mental health services as well, but they were very interested in improving their evidence-based practice and also evaluating the treatment that they do. So they were delivering a lot of treatment, but they really wanted to make sure that they were making a difference on the ground. So they formed this partnership with University of Queensland, and my position arose out of that. So for the last few years, I've been working with Lives Live Well, really quite intimately with their services, with their managers, their team leaders, their counsellors and their clinical governments team. And we've been working on a number of projects. I heard a talk this morning, and I know this is a big thing that's happening across the board, but looking at outcome measures and how do we actually evaluate the treatment that we're delivering to clients and making sure that it's effective. But the other thing that we're interested in outcome measures is how do we actually evaluate clients coming in and ensure that they get the best treatment that's actually meeting their needs. Developing the GRIP program, which is a development from the YMCA program that we did in residential rehabs. We spoke a bit about that yesterday, as well as Quick Fix, which is a brief intervention generally targeted at non-treatment seeking young people, and Full Fix, which is like an extension of Quick Fix, so a more extended treatment, particularly focused on comorbidity. So what I'm going to focus in on now is why am I particularly interested in young people in alcohol and substance use disorder. So Kath Chapman and her team identified that there's an 18-year gap from when someone identifies or when there's evidence that they have a problem with substance use to when they actually go and seek treatment. We know that 75% of alcohol and other drug and mental health problems emerge before the age of 25 years. But we know also that only about 7 to 18% of young people actually seek treatment. And some of the reasons why they don't seek treatment, so Steve Alsop talked about stigma and the perception that we have. I mean, we have a growing acceptance more of mental health and depression, but still seeking treatment for AOD, there is this view, I'm not a junkie, I don't need to do that, I don't have a problem. There can be difficulty accessing treatment. So if you think you're 16, how are you going to get to the treatment service? If it's not right near a train line, even if you're going to, if you have to catch a train, that could be 2 hours out, your parents might wonder where you are, and you don't necessarily want to tell anyone about your AOD treatment. And yet we have this heavy focus on face-to-face treatment. And so if you don't have a driver's license, you don't have a car, or you don't have the means to get there, then you can't really access it. It can be that it's not perceived as a problem. Everyone sees how young people use substances more than anybody else. So if all your friends are using, then what you're doing is no different to them, and you might not actually identify or feel that you can give rise to words saying that you might think you have a problem with it. And then the other thing is just practically, everyone's busy these days, and it can be a low priority, and you'll get around to it later. And if you think about that in relation to your own medical concerns sometimes, if you've got something, you're like, oh, I'll do it next week. So sometimes people just never get around to going and getting the help that they need. The next concerning thing is when treatment is sought, there's about 17 to 25 years between when an evidence-based intervention is developed to when it's actually implemented in practice. So there's this question, if someone actually goes and seeks treatment, are they getting the latest evidence-based, most effective treatment that they possibly can? We also know that even if a site actually implements evidence-based treatment, within 6 years, only 47% have maintained that evidence-based intervention. And there's also a lack of consistency. If someone wants to go and seek out a service, there's a lack of consistency in the type of service that they'll receive or their level of access to evidence-based practice. So in terms of addressing this, first off, I wanted to look at the clients themselves and look at some of the unique factors that AOD clients present with, to examine some of the comorbidities, and then also to examine common barriers and facilitators to intervention and some strategies that might help us as researchers engage with people on the ground. Now, obviously, given my psych background, this is going to be heavily focused on psychosocial treatment models. We've had different discussions about medication and other medical models, but that'll be the slant that we'll be talking about here today. So looking at client factors, I just pulled data from the National Minimum Data Set. So we have 127,000 clients receive treatment. This is 2017-18, which is a 7% increase from 2013 to 14. More than half are 20 to 39 years old. 2/3 are male, most are seeking treatment for their own substance use, and we have 6 times more likely that Aboriginal and Torres Strait Islander people are seeking treatment than non-Indigenous peoples. In terms of primary drug of concern, it is alcohol followed by methamphetamines. I mean, amphetamines is there, but it's predominantly ice, and then cannabis, and as everyone sees, lower doses of heroin. In terms of a referral source, predominantly it's by self or family. That's kind of mixed in together, but often is self-referrals, followed by health service, and then we have corrections and diversions, which is a very interesting thing that arises, and I'm going to talk about the impact that can have on treatment later. So what I'm going to talk about here is just 2 samples. One is a community-based sample. Bear with me, it's only 149 individuals, but it's fairly representative of the samples that we found in the National Minimum Data Set. This one has more females in it, but only 56% have a grade 12 education, and predominantly they were presenting to treatment for alcohol and methamphetamines. So what I was particularly interested here is comorbid presentations with other behavioural concerns, so things like gambling, gaming and problematic pornography use, as well as trauma, depression and anxiety. And I'll just talk through this rather complicated graph, but the green line, if you look at it, is you've got this as your polysubstance users. and they're also engaging in gambling. So we were finding about 25% of the sample had problematic gambling, but they have more moderate levels of trauma, PTSD, and mental health concerns. The purple line had slightly more elevated tobacco and cannabis use, but you can see they've experienced trauma and PTSD, and they have more elevated mental health concerns. And then in terms of the blue line, that's more moderate across the board. So within this sample, there was very high levels of trauma. 70% had experienced a trauma in their lifetime. There was elevated alcohol and tobacco use across the sample, but what we were a bit surprised by was very low reported gaming or problematic pornography use. It really wasn't featuring at all. So looking at a second sample, this was with a residential sample. Once again, it was 194 people. These were all the young people that had entered residential treatment. They were 18 to 35-year-olds. It was about 80% representation of the actual clients that had entered the treatment. Things to note is that 74% were unemployed, and more than 55%, it shouldn't actually be grade 12, it should be grade 10, had finished grade 10. So there was very few that had actually finished past grade 12. 43% were methamphetamine users, and 35% had used alcohol. And this is just an indication of the polysubstance use. So this is on the WHO assist. As you can see, the purple line was that they had high risk on substance use. And what we were finding is that more than 25% had used more than 5 drugs in the last 3 months. But mostly people were using about 3 or 4 drugs when they came in. So it's probably just an interesting thing to note when we have this heavy focus on primary substance of concern. And then this is just looking more broadly. So about a quarter were homeless. You can see 36% were experiencing chronic pain in the last week. 31% had been hospitalised in the last month. 18% were experiencing domestic violence. And you can see arrested, in prison, at risk of eviction. So doing a similar mapping in terms of that, we came out with the same, with 3 classes again. This one was slightly different because we did include psychosis, and what we found was this elevated substance use. So we had a similar kind of elevated substance use, but they were also more likely to screen positive for psychosis. We then had these moderate level across the board. What we found, so the green in particular were more likely to use lots of drugs, and particularly more what you'd associate as party drugs, the MDMA, your inhalants, your hallucinogens, but also they were more likely to experience psychosis. Your second purple group had more moderate levels of substance use in comparison and more elevated PTSD and trauma. And for this group in particular, there really seemed to be this elevated PTSD and trauma that could be impacting on their substance use. And then thirdly, the last group was moderate across the board. So this group also had high levels of trauma. 61% had experienced a trauma in their lifetime. 44% met severe depression, severe anxiety. And the interesting thing I just want to highlight is coming into treatment, 23% had flourishing wellbeing. And oftentimes we don't necessarily talk about that, but in some of the work that we've done, we've found substance users in comparison to other mental health groups are more likely to have flourishing wellbeing. So it is quite a resilient group that we are dealing with. So in terms of psychological treatments, the first thing to highlight is I've highlighted there's a lot of comorbidity, yet unfortunately our funding models and our treatment models, they're kind of 2 silos that operate separately. On the one hand, we have mental health, and you go over there if you want mental health treatment, or you go over there if you want AOD treatment. And oftentimes individuals that are delivering both don't have experience. I think one of my running, it's not really a joke, but if you go to someone with mental health and you're intoxicated, they freak out. They don't know what to do. They're like, someone's coming into my office and they're using substances or they may be intoxicated, what do I do? If you go into an AOD service and you say you're feeling suicidal, they're like, oh no, I don't know what to do with you. And so, unfortunately though, we have clients that could be both intoxicated and suicidal. And it's something that's really important to look at, and some of the language that we're trying to look to be able to upskill some of our AOD workers in mental health interventions. In terms of our agencies, the majority are in major cities. There's 22% in a region and only 7% in remote or very remote areas. So this is within Australia. 58% are non-government, and that widely varies. So from 27% to 100%. The other interesting thing to note is that there is no national minimum qualification required to be an AOD worker. which means when you're working in this field, you can have a very wide variety of skill sets that you're encountering, from people that have, say, postgraduate qualifications to people with Cert 3 qualifications. And so even in terms of working, it can be interesting in terms of trying to tailor that. In terms of the main treatment, it's predominantly counselling. And this is, as I said, psychosocial. So counselling, support and case management, withdrawal, assessment only. But a lot of it is counselling based. In terms of setting, most is done in outpatient settings. So you have a small amount in residential. Other settings were things like outpatient care, so going to somebody's home and delivering treatment there. But as I said, predominantly it is in residential settings. Non-residential settings. And this was something I found interesting in terms of treatment episodes. 80% of clients complete treatment, or they're not in treatment anymore after 3 months. And on average, they're receiving 1.6 treatment episodes. And that's across the board. That's the average number of treatment episodes we're delivering, which makes us kind of look and go, when we're developing a 12-session intervention, in practice, how many people are actually going to be completing that 12-session intervention, which has really made us think about brief interventions. And part of the whole concept of brief intervention is, how do we actually go realistically, if people are only going to come in for 1 or 2 sessions, how do we make sure that we're getting our biggest bang for our buck when they come in, and making sure that they're actually going away with something that is going to be useful to them, and that we're not using the whole first session just doing an assessment and spending that whole time doing an assessment. How do we actually operate in a way where we can have a clinical outcome from that first interaction? And the other thing is, too, thinking about these brief interventions within a broader step care model. Okay, so in terms of implementation factors, what I'm going to talk about here, a lot of it we've been looking at this consolidated framework for implementation research. And we're really interested in this framework because it takes a very comprehensive view of how we do implementation work. It looks at the intervention itself. It also looks at the inner setting, so the counsellors, the caseworkers that are delivering the intervention, as well as the organisation that they're operating in, the funding models that they're operating out of, the culture that they're working within, and then also the clients that they're engaging with. So some of these I'm going to talk about is drawn upon lots of multiple approaches, from the randomised control trials we've been doing, qualitative interviews that we've been conducting with the counsellors, the surveys we've been doing, and a lot of literature reviews within this area. So first thing on clients is thinking about the education level of the clients that we're encountering. As I said, a lot are unemployed, and more than half probably haven't finished beyond grade 10 of school. So if we're doing interventions, we've got to make sure that we're actually catering for that and that it is not too word focused. The other thing is thinking about strengths and supports. This is actually a very resilient group that we're working with. They often have very good social networks. They're highly socially skilled, but oftentimes they have never had anybody that actually recognises their strengths and acknowledges their strengths. More than any other group we've worked with, they've probably never, things we take for granted, like finishing school, or getting just the approval and the accomplishment that comes from that, they've never experienced. And oftentimes they've probably had everybody tell them how bad they are and how they've done everything wrong. And so it can be quite powerful if somebody actually recognises some of their strengths and some of the things that they can actually contribute to society. It's also very complex presentations in terms of homelessness, suicidality, mental health concerns. And one of the things we've been finding is lots of clients come to treatment when they're in crisis. That's one of the incentives for them to come to treatment. And if you spend your whole treatment episode just dealing with a crisis, then you never actually get an opportunity to do an intervention with them. And so that really focuses in on the policies and the procedures and the links for the counsellors to be able to have the confidence to deal with the presenting concern, but at the same time still deliver treatment within that episode. We spoke about access to services, and one of the things we're particularly trying to look at is telehealth-based services. The other thing that's kind of novel with this group, and I think seeing some of the talks that we had about people who, even if they're on a win, they'll leave the win, is it's no funders think about actually, do we follow up a client? As opposed to the client always coming to us. If we have a client that's clearly engaged, could we try and put in some effort to actively follow up that client? So we can actually reach out to that client, particularly if they've already expressed an interest in getting treatment. Is there some way that we could think about that within our models? I already kind of mentioned typical attendance, but we have to be practical. If somebody's not turning up, we need to actually meet the client where they are and make sure that we target and tailor treatment so that it's meeting those needs and the attendance of clients. And then finally, corrections involvement. One of the big things about treatment, if we want to actually work with someone, we need an honest picture of where that person's at. And if they're concerned that their records could be subpoenaed by the court and then they're going to get sent back into jail because they've violated their parole, it's very hard to do treatment with people. And so I think that's one of the ongoing challenges is how do we do that and how can we develop a system working with people so that they can talk to us about their treatment and we can look at improvements. In terms of counsellors, one of the biggest things I'd say is exposure and understanding of research. There are a lot of really good marketing campaigns of people that say that they're delivering evidence-based practice, and when you actually look at it, it's got no evidence at all. It's got a lot of pretty pictures, and they have a really good supposed training delivery model, but there's actually no evidence behind it. And if you're someone on the ground, you don't necessarily know the difference. And so it's very important for us to actually actively go out and educate people on the ground, to inform them about what is evidence-based treatment, what should they be looking out for. And if we can have some kind of common language that we're using in communicating, and in all the training that we may give, making sure that we're really heavily presenting that evidence base, it's very important. And the other thing is the rapport and the relationship. And I went to a talk this morning and they emphasised that, but it can't be researchers coming in and saying, we know how to do it best, so let us tell you. It really has to be what's important to you, but also recognising we do have something to offer. Like we know a lot, and if we work together, then we're going to end up with the most optimal outcomes for the clients. And I think the beautiful thing that we have at the moment, like a potential in it, is be able to have this working relationship. And you need years in terms of investing in that relationship to understand the different language that you both use, to understand what's important to both of you, and to be able to meet that common ground. Mental health and comorbid interventions. One of the things we found really interesting, we've got a comorbid intervention, and we had some counsellors go, I don't do mental health. I'm not experiencing that. I can't deliver that. And we said to them, okay, we understand that. We're not doing mental health. What we're doing is these are some factors that could be maintaining the substance use. So we're just teaching some coping strategies to target factors that could be implementing substance use. Would you be happy to do that? And they said, yeah, I'm happy to do that. And we didn't change the training. They're still doing mental health intervention. But from their perspective, it's focused on AOD. It's still within their area of expertise. As I said, trying to move towards telehealth interventions. And with counsellors and caseworkers, it is a very, very big shift. If you have somebody in the room, you can see all the body language, the way that you can interact with them. And also, if they're at risk, they're right there at risk in the room with you. If you've got somebody over the phone, you can't see them. If they tell you they're suicidal, you have no way to put practical constraints in place to help them. And so it can be very daunting and very overwhelming. And so more training is needed to help people move from a face-to-face model into a telehealth model so that they can do both. And I think some of those realistic limitations within a telehealth model need to be acknowledged. And it's not that we can't move there, but that we need to actually increase that confidence because it's a realistic concern. Working with non-treatment seeking clients, we found this one quite interesting. So within Quick Fix, we were implementing it within some school settings, and we had young people coming in, and one of the questions we had on our survey was, are you receiving treatment or have you received treatment in the last month? And they were all saying no, and we found that a bit strange because we knew some of them had. And so we got them to ask, can you please ask them? And they said, well, you know, when you read treatment, what do you think that is? They're like, I'm not in treatment, I'm not in resi rehab. And they're like, oh, okay, so what's treatment? Treatment means you go away, you're in a resi rehab. Like, okay, why do you think that? Oh, because that's what all the movies say. So everybody that's in treatment is in resi. And they're like, okay, have you been in counselling? No, I don't need counselling. I'd never go to counselling. Okay, so what are we doing? We're just talking about our substance use. Okay, so you're happy to meet up with me every week and just talk about our substance use? Yeah, I'm cool with doing that. That's fine, no worries. So, I mean, that was something we'd find, like, if you have someone that calls a young person and goes, I'm so-and-so from the alcohol and drug service, and I'm here to talk to you about your alcohol and drugs, they all hang up. But if you have someone go, hey, how you doing? How was your weekend? You want to chat with me a little bit about you know, what you did on the weekend? They're like, yeah, cool, I'm happy to do that. And so some of that as well is when you're moving from people that are actively seeking treatment to people that are they're just dipping their toe in the water, we have to be conscious of that and use the language that's appropriate to them. And the other one is manualised treatment. A lot of the people we were working with, a common thing is I want to go with the client wherever they're at. I want to be flexible and I want to go with the client wherever they're at. And if I implement evidence-based treatment, then I'm not listening to my client and I'm not listening to my client's needs. And it's a challenge because if you're trying to standardise treatment that clients are delivering, if you're trying to make sure that there is a consistent form of treatment that clients are receiving, and if you're trying to actually evaluate it and making sure everyone's on a similar level, then manualised treatment can be the first step and the easiest way to go in that. But in it, we have to make sure that we present it and we teach it in a way that is still flexible enough to meet the client's needs. And one of the easiest way I found to counter this was I said, okay, can we please do a role play? I'm going to be the counsellor, you're going to be the client. Think about one of your clients and we're going to go through and we're going to do this according to the manual and I'll do it with you. And so we did that, and then at the end of the session I said to them, how did you feel? Like, how did you find that? And they said, oh, I felt really listened to, I felt heard, I felt respected, and I felt like it was really useful in helping me manage my substance use. And so I think practical demonstrations with this group are really, really important. And then once you do the practical demonstration, actually giving them the support to be able to implement it, which I'll talk about in a bit. In terms of the intervention, obviously it has to be relevant, not just to the client, but to the counsellors. It also needs to be relevant to their funding model. Counsellors may love it, they may think it's really important, but if it doesn't fit their funding model, they're a bit restricted. Language, I kind of already spoke about that. Language for the client, language for the counsellors, and simple. Not just for the client, but for the counsellors as well. The more simple it is, the more people are going to feel confident in delivering it, the more they're going to be able to impart it, and if someone comes in crisis, the more they're going to be able to understand it. I spoke about this a lot yesterday, but concrete and practical. I think we need to move away from even worksheets where you write in everything. In a lot of the work we've done, we have colouring in pencils, stickers, where people can draw and also engage in practical physical activities. It's kind of been spoken about, but fitting within the current processes, and that's in terms of this relationship, really sitting down with the clinical governance team and going, what are your processes and where can we map things in? How does it fit in with your technological systems? How does it fit in with what you currently do with clients? Where do clients come in the door? How do we work? And then support materials. This is one of the big, counsellors really see that you can contribute a lot in terms of the support materials. And whether that's physical, paper-based, which is where I would recommend you start because we're dealing with a group that doesn't like technology, but also web-based supports for counsellors can be very powerful, counsellors and clients. That's kind of in the wrong place. But I think this is kind of just highlighting what I said before with the evidence base. I think we shouldn't be afraid of actually talking about systematic reviews, randomised control trials, the theory behind what we're doing, why we're doing it, why have we picked a particular intervention for this client group. So for instance, this is looking at the latest psychological treatment for methamphetamine use and about how cognitive behavioural therapy, contingency management, how they can be used within these treatment settings. The other thing I'd say with evidence-based treatment is across organisations, I often hear that we're using a evidence-informed model. So one of the things, I went to a talk and it's completely different, but looking at depression and mental health. And they did an intervention and they said the treatment has to be targeted to the actual problem that you're trying to address. So for instance, cognitive behavioural therapy is highly effective for anxiety. Counselling-based therapy can be very effective for depression, but hasn't been shown to be as effective for anxiety. Whereas people go, well, it works for depression, so I'm going to use it for anxiety. And what they found is it'll work for 46% of your clients. But if you were to use CBT, it would work for 69% of your clients. And so sometimes I think what we need to, when we talked about anecdotes, like Steve Alsop talked about the power of anecdotes, and counsellors may go, that works for one of my clients, so I'm going to use it with all of my clients. The advantage of research is we go, we want to actually have the best outcome for the most clients that we possibly can have. So are you going to take a 43% chance, or do you want the 69% chance? And part of it's trying to communicate that and help people use the strongest evidence we can for the clients. Flexibility, sorry, I spoke about this already, but being able to have step